Sara Fogarty. She's from the Sandra and Malcolm Berman Comprehensive Breast Care Center at GBMC. Right out of the gate. That is a mouthful, isn't it, Dr.
Yes,
Fogarty?
It is. It is.
And we're going to be talking about breast cancer treatment updates today.
Yes. Thank you so much for having me.
Well, thank you for being here. Sure. This is great, and we've been all over social media and talking about doing this today. And we're so happy to have you here. And you're so much fun already before the cameras turned on. We're just getting along famously, and you're very easy to talk to.
Thank you.
See why you're so great with your patients, and that's just sort of a casual conversation. It's a really nice way with these GBMC Facebook Lives it's another way for patients and for people to sort of get in touch with their doctor in a different way and get information.
Absolutely, absolutely.
Yeah, so we're super excited. So we might as well get started, I guess, right? We got a ton of questions to get to. So
yes.
Years ago, it seemed like everyone with breast cancer got a mastectomy.
Yes.
And that's what we heard in our younger days. But these days, it doesn't seem like that's the case. So why the change?
That's absolutely not the case anymore. We really, over the last 50 years, people that we used to do mastectomies for breast cancer all the time. That was the only thing we knew. Breast cancer was really a surgical disease. That's how we treated it. And, being in Baltimore, it's significant just because Halstead was the father of general surgery in this country, and he performed the radical mastectomy first in the late 1800s to cure breast cancer. And from that time, that was a very disfiguring surgery, and that was the standard of care for a really long time.
Wow, I didn't know that.
But as we learned more and did research and realized that even patients that got these huge surgeries, might not have survived, we realized that surgery wasn't really the right, the only treatment we have. And of course, nowadays we have so many drugs to treat breast cancer. Our surgeries most of the time can be very small, and we really strive to do what's called breast conserving therapy, which is a lumpectomy, which I'm sure a lot of people have heard that term before. Mm-hmm. Basically removing the lump or the cancer that we've seen on imaging. And so that's something that our center really was built on, the founding principles that we could do smaller surgeries. And so we really try to do breast conserving surgery on every patient that's eligible for it. Mastectomies we do have to do, and medically, for medical reasons to do mastectomy, really if they have cancer all over the breast or just so much disease that we're not able to do lumpectomies successfully. But we really try to do breast conserving surgery whenever possible.
Good to know. This is such great info. And so what are some of the most common types of breast cancer removal surgery that you see now?
Sure. So lumpectomies are really our standard, and our, any breast center that's accredited, which we are, of course, it really strives to have a high rate of of lumpectomies. And so our normal standards, I think every year we're about 70% of patients get lumpectomies. And that's basically all it is. If you have a lump that you can feel or on imaging, you basically just take out that area of tissue, and you make sure to take margins around it to clear any disease, any microscopic disease that you can't feel. Our surgeries are very small. They're all outpatient procedures. We make a small single incision, and that's usually all we need to take out the cancer. So women, when I talk to them and they first meet me, they think, oh my gosh, I'm going to have a mastectomy. This is terrible. And I usually surprise them by saying, no, absolutely not. You don't need that. Some women want that, and that's a whole different issue. I mean, medically speaking, we don't, I don't recommend it for medical reasons, but some women do want them, and I usually, sometimes I can't convince them that they don't need it.
Yeah, we'll get into that too. Is that what you've been hearing sometimes with genetic testing, or if someone is predisposed in their family to breast cancer?
Yeah, absolutely. And there's a lot of reasons that women feel that way, but really the risk of recurrence these days, they did studies in the 1970s looking at this question. Do you need a mastectomy? Can we do a lumpectomy safely? And the lumpectomy group with radiation have about the same amount of recurrence rates as the mastectomy group. So women don't understand that. They think if they have a mastectomy, their breast cancer will never come back, and that's not the case. They still have a risk of having a recurrence.
Wow.
There's no way anyone can ever remove every single cell in the breast, and so you couldn't get a recurrence. And it doesn't happen often, but it can happen. So
that's reassuring information, isn't it?
So we try very hard to do smaller surgeries with the same outcomes, and people are usually very happy with that.
That's fantastic. And you make it seem so easy to talk about and not scary at all.
I try to. I think that's the biggest, that's part of what we do in our office, is really try to calm people down and make them feel better. I usually say to them, I hope I make you feel better by the end of this appointment, because people come in obviously very upset.
Yeah. I bet you do that. That's great.
Yeah, and usually once we get through all of this, and if they need surgery as their primary, their first treatment in their course of treatment for cancer, that I can, at least get rid of that fear and tell them, you really don't need to have that done. We do them, but it's, medically necessary mastectomies are not that common.
Good to know. So why would someone choose one procedure over another? Or is that something that you would discuss with your patient?
And that's
with your
a lot
options?
of what I discuss
Yeah.
when I see patients for the first time, and we spend a lot of time going over all the surgical options, all the risks, all the benefits. Some women come in saying, I'm having mastectomies, that's all I want to do, I want to hear nothing else, and I usually at least try to go over why they don't need it done, or if they do, what we do and how we do reconstruction and what our options are for that. A lot of women are relieved to hear they don't need a bigger surgery. So a lot of my patients that I tell them you can have a lumpectomy, they say, great, that sounds perfect, we'll go that route. So it's a very straightforward, it's a 1 hour long procedure. Outpatient, minimal pain. I mean, people do very well with recovery.
Good to know. What is lymph node dissection is one of our questions that came in.
Sure. Well, so every patient that has an invasive breast cancer, we usually sample a lymph node called a sentinel node biopsy to show or to prove that there isn't cancer that has already spread from the breast into the lymph nodes. The way breast cancer can spread is it goes from the breast to the lymph nodes, and that's how it can get into the bloodstream.
Oh.
So back in the day when we were doing these large, mastectomies, everyone got an axillary dissection, is what that's called, where we remove all the lymph nodes under the armpit on the affected side. We do still have to do that occasionally, but it's, again, much less common. Most women can have a sentinel lymph node biopsy as their lymph node surgery to prove if there's cancer in the lymph node or not. The way we do that is with dyes. So we have 2 dyes that get injected into the breast, and the dyes are basically pathfinders. So they identify for us the correct lymph node in the armpit the cancer would go to first. Yeah, it's great.
It's amazing the strides that have been made and how you've targeted so many things.
And we've been doing that since 1998. So it's a very, we've been doing it for decades. And it's a very
common
It works
practice.
very well, and we do it standard of care.
Very cool.
An axillary dissection is indicated for women with positive lymph nodes, meaning there's disease in the lymph nodes. And so sometimes we do have to remove all the lymph nodes. And basically what we do is, when we look in the armpit, we don't see all the lymph nodes. Everyone has a different amount. I never know how many when I'm doing it, but I basically take out just a pad of fat in the armpit that has a bunch of lymph nodes in it, and then the pathologist looks through all of it for us to tell us if there's, how much disease is there. So we do still do them, but it's, again, we've gotten much smaller with our surgeries over the decades from what used to be the standard of care.
Now, can that procedure be done without having a lumpectomy or mastectomy?
Yes, it can. Usually when I'm seeing a patient for the first time and they're newly diagnosed, they haven't had anything done. I mean, a lot of times we'll do a sentinel node biopsy, and if that node comes back with disease in it, then the standard has been to say you need to have a complete lymph node dissection. And so we would take them back to the OR to do that separately, even if their breast surgery's already been done. So yeah, we can do that, absolutely. But we want to make sure we treat the cancer in the breast also and remove that.
Right, right. Does GBMC offer many reconstructive options too?
Absolutely. Everything that you could think of. We have a fantastic plastic surgery team, and we do reconstruction a lot. We actually do a lot of lumpectomies and reductions at the same time for our women that are larger that want to be smaller or have thought about doing reductions anyway, and that's a procedure that everyone loves because not only do they get their cancer removed, but then they get to be smaller, and they're very happy with that. But we do implant reconstruction. We do direct implant reconstruction for women that are maybe smaller sized or want to stay the same size. We can just put a direct implant in. Usually it's a 2-stage procedure where we do something called tissue expanders. They're like water balloons. And we put those in after we do the mastectomy, blow the patient up, over weeks to months to the size they want to be, and then we do a second procedure where they remove the expanders and put in an implant. Oh, wow. So we do that very often. We also do a lot of flap reconstructions. We're taking your own tissue, your back, your tummy. Some people love that idea. They can get a tummy tuck at the same time as their mastectomy.
And that's probably cost effective as well, I would think, is to do that all at the same time.
Well, and this is all for cancer treatment, so this is all covered. These aren't cosmetic procedures.
Right.
So women, we can do anything, you know, that women are interested in. A lot of women come in saying, I had a friend that had this done, I'm interested in that. And our plastic surgeons see our patients with us all the time in consultation. We work together in the OR all the time, which a lot of places don't do. So we save time in the OR and anesthesia time.
That's right.
So, you know, I'll be doing my mastectomy and my plastic surgeon's right there, and as soon as I'm finished with one side, she'll start, and then I start the other side, and it works really well. Patients, you know, don't need to be under anesthesia for as long. So
very smart choices.
So we can, you know, we can do any. There's millions of options for reconstruction. We talk to our patients about all options and then decide what's right for them.
That's perfect. And Nancy says that Dr. Fogarty is the best. Don't we love compliments? Caring, compassionate, understanding, very down to earth. We're going to make her blush. Nobody wants to go through cancer, but I'm glad she was with me during my journey with it.
That's sweet.
Isn't that sweet? I'm sure you hear that a lot.
I mean, it's always nice to hear it.
Yeah, you definitely love to hear that. And Jessica says, can anyone benefit from genetic testing for breast cancer, or is it only for people who have certain risk factors? That's a really good question also from Jessica.
Yeah, so we have a great genetics center. I send a lot of people there. Obviously, so you know, a lot of women come in, and breast cancer is the most common female cancer. So a lot of women come in saying, my mom had this, my sister had this, my aunt had this. And we take family history into account to decide who needs genetic testing or not. And there's very clear guidelines on who should be tested and who shouldn't. We as a center, we do not, you know, I send patients to the genetic counselors for evaluation and to decide if testing is necessary. I never order testing myself, just because it's a really complicated conversation. I'm not a trained geneticist. You know, I know a lot about it and I know who should be tested, but I never actually send the testing off. I have them meet our counselors, who are fantastic, who see all of our breast cancer patients and all of our cancer patients in the whole center. And to have them evaluated, because nowadays there's a lot of different genes. So there aren't just the BRCA genes that we've known about for a long time. You know, after Angelina Jolie and that whole...
Right. So yeah, I was going to ask for people at home that might not know the medical jargon. So what is BRCA1?
Breast cancer gene. So 1 and 2.
That's 1, and then there's a BRCA2 gene.
Those are genes that everyone talks about and has heard about. Really, it came out into the mainstream media and the general population.
Does that help when celebrities use that platform, or do you find that sometimes is confusing, or I mean, you can ultimately explain to your patients what they need?
I think it can be confusing because people hear about it and think, oh, that, you know, my mom had breast cancer, that must be what I had.
I should do that, yeah.
But I think anyone that has heard these things on TV or in the media, and then they, you know, they should see their doctor and talk to them about it, and they can get the correct
Us Weekly
information.
No,
Us Weekly should not be a substitution for your physician.
Absolutely.
So a lot of people have heard about those genes.
Right.
But there's a lot of other genes that we know about that also can increase your risk of breast cancer.
And what are those like? They have different names, I would assume.
I mean,
does that get too technical for people? That's something, if that were...
the ATM gene, the CHEK2 gene, there's a lot of genes.
A lot of genes, right.
But so they're panel tests now. So we don't even just test for the BRCA genes. We test for panels of genes based on a patient's history. And so if they have history of other cancers like colon or ovarian or thyroid, you know, we look at those things, and my genetic counselors are extremely, you know, educated and very good at looking at patients' history and say, okay, this is what we should test you for, all of, you know, this 9 panel of genes. Even patients that got tested, you know, 10 years ago now, we're sending back to our genetic counselors to be reevaluated because we know more. And every year we know more. Every year there are more genes that come out. And, you know, there's families where you see a patient who's had a lot of breast cancer or ovarian cancer in the family. You think they're going to have a genetic mutation, and then they don't. They could have a genetic mutation we don't even know about yet. So I send a lot of people there. I think that in general, anyone with breast cancer, you know, young breast cancer patients under 50, we send everybody there to the genetic counselors to be evaluated and to most likely be tested. different types of breast cancer, the triple negative breast cancers under 60, we send our genetic counselors. Patients with an extremely strong family history, we send. So we do send a lot of people to be evaluated. It doesn't always mean you'll be tested.
Right.
And so I leave that up to the genetic counselors to determine who needs testing and which panels to run.
Very smart.
So yes, it's a very important part of our, you know, our comprehensive cancer center, and a lot of people are seen at our genetics, you know.
Is it mostly women that you're seeing, or men also?
I see mostly women. I mean, I definitely have had a few male patients. I have male patients that have a BRCA gene, and I will follow them.
Okay.
That have not had breast cancer, but they were tested because someone in their family member, you know, a sibling or a mom or dad was tested because of their cancer and was found to be positive. Then they tested, found to be positive, and so I will follow some male patients that have usually the BRCA2 gene.
BRCA2. We're learning something new today. BRCA1, BRCA2. Got it. That's cool. So, but mostly women, though.
Yeah, mostly women.
Yeah.
I have a few male patients, but not many.
Gotcha. Radiation treatment seems to be, you know, more than 5 weeks, kind of a large time commitment. So is there a less time-intensive treatment option for someone who has that on their mind?
Yes, absolutely. So radiation, with us doing lumpectomies for most of our patients, radiation is usually indicated, and there are definitely patients that don't need radiation, but that's part of the standard treatment. Radiation with a lumpectomy, you know, this equals recurrence rates for mastectomy, so that's why radiation is usually an integral part of our treatment. And radiation, the standard, is about 6 weeks, 6.5 weeks, and that's for the whole breast. So they radiate the entire breast to basically sterilize or kill any cancer cells that could potentially still be there that haven't shown up on imaging, that, you know, my surgery was done, I did the lumpectomy, I took out the margins, there was no cancer left on any of my margins, but what if there was a cell somewhere else? And so they're sterilizing the breast. It helps reduce the risk of recurrence. And so for 6.5 weeks or so is the recommendation, and it is a long time. Now, we also have it's called a hypofractionated course, meaning a shorter course, and basically the dosage is the same over that time period, but they give it a little higher dose every day, so they can do it in only about 3.5 to 4 weeks.
Okay. And you again would determine if that's appropriate.
So the radiation, my radiation oncologists, who we work very closely together, they will see the patient and determine if they're eligible to have that course done. So that is shorter. We also offer something really exciting called intraoperative radiation treatment, which we've been doing since 2014. A lot of centers are doing it, but you know, around us we're one of the only ones, and we.
I was going to ask if it was exclusive to GBMC or started.
We started it pretty early. I mean, a lot. We're on a clinical trial, and a lot of places are. There's, I think, 50 centers across the country on trial with the one company we're working with. But basically, you can offer women that meet certain criteria, and they're very strict criteria, but to give a dose of radiation in the OR at the time of my surgery when I'm doing a lumpectomy.
Wow.
And they can get one dose, and that's it. And so the women that are eligible for it, it is strict. So they usually are women that have very low risk features of their cancer, meaning risk of recurrence is really low. And so women that have smaller tumors, that are estrogen positive.
So there's a lot of factors.
There's a lot of factors that go into it. They have to be a certain age. And so, you know, when I have a woman that meets criteria, it's very exciting.
Yeah.
For me and for them.
I bet it is.
And usually most women are very excited to be able to do it if they meet criteria, and then they see my radiation doctors, who then will make sure they fit criteria and then say, yes, you're eligible, and they come into the OR with us to do the procedure. So it's great.
I know. Again, we're talking about... yeah, we wanted to talk about an upcoming Facebook Live.
My colleague, Dr. Patel, she's a radiation oncologist that I work very closely with, and she does a lot of these cases with us, and she's doing a Facebook Live on October 19th. So she'll be able to answer a lot more questions about it, but it's something that we try to do all the time. I think I have a case coming up in a week. So anytime we have a patient that's eligible, it's an exciting thing to offer. That fits under the category of partial breast radiation, so it's not radiating the whole breast, it's just radiating basically the tumor bed where I removed the tumor. And they've been finding that recurrence rates so far have been low, you know.
Oh, good.
And so obviously we don't have a lot of long-term follow-up, but it's something that we are offering a very select, you know, few patients that fit the criteria. There is partial breast methods that are also available where they actually leave a catheter in the breast for a week or two, and they can get treatments just twice a day for a week. That's something that we don't currently offer, but it's definitely, there's a lot of options for radiation. It does not usually, it doesn't have to be the 6-week course. But again, every patient's different, and whoever meets criteria, the radiation doctor has to evaluate and see who meets criteria for what options.
So it's not offered to every patient, but if it's appropriate.
No, it has to be appropriate.
Yeah. And does everyone that has okay, we'll start again. This is live, everyone. Facebook Live with GBMC Dr. Sara Fogarty and Gina Crash having trouble with her words. Does everyone that has breast cancer need chemotherapy and radiation? I made it.
No.
That's my question. Okay.
No, they don't. Every patient's different, and I always tell patients when we have to look at a lot of factors of their breast cancer, and so as medicine gets more and more personalized, it's something in breast cancer we've been doing for a while. We have to look at certain things that what their breast cancer looks like and what it's doing. And so not everyone that has breast cancer needs chemo at all. Not everyone needs radiation. It really depends on a lot of factors. And so just because you get a diagnosis, that's another thing. A lot of people come in saying, I'm going to have a terrible mastectomy and chemo, and that's not
not necessarily the case at all.
We have to go through everything, all of their factors and why they would need that or not. So I also try to tell people, most people at my appointment, when I first see them, I usually am the first person to see them when they get diagnosed. I can usually tell them definitely if they need chemo, or I say I don't know. Because sometimes
and it's okay to say I don't
we
know.
have to wait until their surgery's done to understand if there's disease in the lymph nodes. There's genetic testing we do on the tumor itself, not on the patient, but on the tumor to see, are they really at a high risk? Should they get chemo? Is that an important part of their treatment? And so that's something that our medical oncologists do a lot for our patients that maybe they look like on their pathology they don't need chemo, but maybe they do just based on the tumor genetics. So that's something we're doing too. I mean, a lot of advances in the last 15 years.
Absolutely, and that's what we're talking about is breast cancer treatment updates here with Dr. Sara Ferguson from the Sandra and Dr. Sara Fogarty. Good Lord. I'm going to just stop talking right now. And I'm not even going to try to say from the Sandra and Malcolm Berman Comprehensive Breast Care Center at GBMC, but I did it that time.
You did.
Okay, now thankfully Nancy's going to save me with this excellent question. I'll try to do it justice. What can breast cancer patients do to alleviate post-treatment fatigue that is serious enough to interfere with both personal life and professional life?
That is something that a lot of patients can have. I mean, I guess a time frame, are they just out of treatment? Have they been done for a long time? I mean, there's a lot of things that could cause fatigue after treatment. During radiation, people get fatigued. During chemo, people get fatigued. Most of those things do resolve. You definitely want to rule out anything that's causing it, like anemia. Depression can cause fatigue. That's true. A lot of women, this is a very hard time in their lives, and that's something that can also be contributing. I think that's something that you definitely need to talk about with your, if you have a medical oncologist currently or your primary care doctor, to make sure to rule out any medical cause for the fatigue. I mean, anemia is something that we see with radiation and with chemotherapy, and so that can definitely cause exhaustion.
That makes total sense.
Exercise, nutrition, lifestyle, all of those things are important too, and that's something that, even if you're exhausted, exercising can really help that. I mean, there's a lot of factors that could play into it.
That's very true.
If this is something that's, unrelenting and consistent even years after treatment, I'd want to make sure there's nothing else going on that's causing fatigue. But underlying, depression can also be a big factor. And after having breast cancer and being treated, that's something that a lot.
Do you see that a lot generally, or?
Well, I see it more in the acute. They just got diagnosed. It's very upsetting. People don't sleep, don't eat. They're, obviously worrying. And usually that's something that hopefully will, as they get through treatment, improves. But our center is really unique in that we have a psychiatrist on staff who only sees our cancer patients for us as a cost that we cover. And we have patients that we refer everybody to talk to her. To see, she can help them get through the initial, period where they're having a really hard time. Patients sometimes continue on with her for a long time. And she's just a huge part of our center. She's been with us a long time. I send a lot of patients to talk to her. My nurse navigator, Barbara Raxon, is a fantastic asset, and she helps get people to talk to her, and she speaks with her all the time about all of our patients. So that's something that is really unique to us. I don't know of any other centers that offer this service. Is something that is free to our patients.
What an amazing resource.
Yeah, it's really an important thing, and
that's great.
A lot of our patients see her and talk to her.
And you hear nurse navigator a lot. For somebody who might be watching this Facebook Live and not know what a nurse navigator is, what is that?
So a lot of most cancer centers will have a nurse navigator, and they basically are people that help patients get through their treatment and get their appointments made, get to where they need to be, make sure that they have everything in place. If they have, issues with social stuff, just like home life issues, transportation issues, I mean, they can really help coordinate a lot of things for our patients. Our cancer center has a huge, that's a huge component of them. And so we have a nurse navigator specifically at the breast center, Barbara, who's amazing and cannot help us enough with all of our patients. She takes care of everybody like they're her own family. And then the cancer center also has their own as well that really helps get people make sure their appointments get made, make sure they get the right follow-up, make sure they get through all their treatments.
Good. Really good to have an advocate for you on your side there. And we have one more question here before we wrap things up and let people know what else is coming up on our GBMC Facebook Lives in the future here. What time in a woman's cycle, this is from Maria, is the best time to get a mammogram, or does it not really matter?
It doesn't matter for a mammogram. You can get a mammogram anytime, and so the screening is controversial, but most people should are screening every year. It has nothing to do with the woman's menstrual cycle.
Wow. So we learned so many things today, but that's something I think maybe not everybody knows, and they certainly do now.
Yep.
After having Dr. Sara Fogarty on today with us, talking about breast cancer treatment updates, and there are many, and there's a lot of hope, and you guys are doing great work every day. Thank you so much for joining us from the Sandra and Malcolm Berman Comprehensive Breast Care Center at GBMC, and we have a whole day's worth of Facebook Lives coming up with our friends at GBMC. Up next, our friend Mary Beth Marsden will be hosting with Lanny Dowell, who is a doula, and they'll be talking about postpartum care for the new mom. So that's another interesting topic coming up today from 1 to 1:30, so be sure to get your questions in that way as well. I'm Gina Crash. We want to thank you for watching this GBMC Facebook Live today, and we'll see you again next time. Thanks so much.
Thank you.
Thanks for all your questions.